So a very relevant problem for India currently is increasing burden of STEMI. Plus, because of all the logistic delays, patients are not able to get the gold standard treatment, which is primary PCI. In the current scenario, how do you advise, or what is your recommendation? How do we manage patients with STEMI, sir?
Yeah, you see, we know the literature from the Western world that they have a very good workup that anywhere when the patient is getting a disabling chest pain, they can call somebody, especially in US, where we 911, within a fraction of seconds or minutes, people will be there. They can be taken home and taken to the hospital, and the primary angioplasty can be done within a period of say 1 hour to 90 minutes. And that may be considered as the golden standard, whereby you can achieve almost a complete salvage of the myocardium by restoring the blood flow. Now, in Indian scenario, we are facing a lot of hazards like traffic problems, and the patients where they are unable to detect the symptoms because of the ignorance or their lack of knowledge, that they are unable to fish out the symptoms, by which there itself is a delay, and they themselves try to treat the problem with what sort of medicine which is available at home. They are reluctant, and there is something called denial also. So these things all will come together and impact on the time which is taken to reach the hospital. So once they decide to reach the hospital, there is again the traffic problem. We have always in Kerala, we have done a study on behalf of when I was state president of the Indian College of Cardiology. We conducted a study here up to what percent of people reaches the hospital on time after getting a disabling chest pain. This study was conducted not the problems encountered inside the hospital but outside the hospital, from the time of the onset of chest pain till he reaches the doors of the hospital. There are a lot of problems. And these problems, mainly the traffic problems encountered. There is no preference for the ambulance or to get a taxi, to get a vehicle. It is impossible. So once they reach the hospital, naturally the hospital machinery starts functioning. So until then, this is a big problem. So the patient can reach a center where a pharmacotherapy, that is a lytic treatment, can be addressed. And after that, immediately the patient can be referred to a tertiary care center where the cath lab facility is there. And that may be an optimal way of treatment to address the issues, complications of myocardial infarction in the Indian scenario, because most of the people are facing these problems. Only in the big cities where they are having a very good traffic is not a big problem, or they are able to reach the hospital on time in particular hours or something, that golden hour, the primary angioplasty. So in our study, what we found was almost 12% of the people only are able to reach the hospital within a period of almost 4 to 6 hours. That means almost 85% of the people are reaching beyond that period of primary angioplasty. So doing primary angioplasty beyond that particular time limit will not also bring much effect. So in those conditions, reach a hospital where the lytic treatment can be done, get it done, and then plan for. That may be ideal.
Pharmaco-invasive approach probably provide the reperfusion in terms of lysis at the earliest possible point, and then probably shift the patient to a higher center where primary PCI or further investigation and workup would be done.
That's right. That's right.
So in terms of selection of thrombolytic, what is your stand? Like there are available 3 agents in India.
We know that our good old streptokinase is still prevalent, but it has a lot of side effects, like allergy problem is there, hypertension is there, and nowadays we are more in favor of a tenecteplase, which has a very high potency for restoring the blood flow. Naturally, it is expensive for Indian scenario. About 30,000 rupees approximately will be coming for a treatment, but it is very efficacious, and I think most of the hospitals in India are now using connected place.
And outside India, that's the only thrombolytic which
Only
is
thrombolytic,
available.
only thrombolytic.
US and Europe, streptokinase is not
Not
there
avail-
anymore.
There's no need because they are fully covered with the insurance and all.
Insurance.
Yeah,
True,
yeah,
true,
yeah, yeah.
Any other message you want to give to physicians who are the primary first point of contact for myocardial infarction
That's right,
patients?
that's
That
right.
What should be their approach in managing
See,
these patients?
most of the time we see GPs or physicians may be lesser, but GPs may be more when a patient comes with a disabling chest pain, simulating a heart attack. It need not be a heart attack, could be also some non-cardiac chest pain.
Sure.
Whatever may be the quantity of pain or anything, the patient has to be observed. That is rule number one. I instruct my junior doctors in the casualty when a patient comes with a disabling chest pain, and if you think that it may be a heart attack, it may be something else. Whatever may be your presumption, admit the patient if you suspect that it's not purely a young patient without risk factors, a costochondral pain. Once you pressurize the chest wall, if it is a typical costochondral pain, you can send. But otherwise, a elderly patient or a middle-aged patient with the risk factors, once you take the history, probability of getting a heart attack, even though your ECG is not providing adequate evidence, chest pain is there, ongoing chest pain, for heaven's sake, admit minimum for a period of 24 hours, take serial ECGs, take troponins, and come to a conclusion, because that may be detrimental if you send the patient home without adequate treatment or anything. So, suspected cases, a question of 24 hours in the hospital is not a big issue. Admit the patient and keep on doing the serial investigations like ECGs, troponin, maybe a bedside echo to know any regional wall motion abnormality, etc. And if you find the patient is definitely symptomatic and you are going to face a acute coronary syndrome, treatment should be addressed accordingly. If within 24 hours, if the patient does not have any evidence of chest pain, any myocardial infarction or ACS, depending on the ECG changes or blood works or anything, and it turns out to be a typical infective problem or a costochondral problem, etc., send the patient with an antibiotic or something. But never dare to send a patient who is coming to the hospital with a chest pain. True. Because you do not know how it is going to be in the coming hours or minutes to come.
Right. I think that's a very important message which physicians should take on, that they should not ignore any chest pain.
Absolutely,
and should follow up this patient till they are 100% able to exclude that it's a cardiac pain. Thank you, sir. Thanks a lot for joining today. Thank you, sir.
Thank you very much.
Current scenario, how do you advise, or what is your recommendation? How do we manage patients with STEMI, sir?
Yeah, you see, we know the literature from the